Good morning, everyone. Today I will be presenting on behalf of Medicine 2, Impotes Mentis. So, Mrs. X, 62-year-old female from Bangladesh, presented with breathlessness for 1 month. Initially, she had breathlessness only on accession NYHA class 2, then later progressed when on arrival, she had NYHA class 4 breathlessness with orthopnea symptoms. Along with that, she had chest pain for last 2 days. It was sudden onset over the center, radiating to back and left side of the hands. So past history was she's a known case of diabetes for the last 20 years and old case of CV on 2020 and 2021 with the left side hemiparesis and left facial palsy with minimal residual weakness effect. And she is a known case of hypothyroidism for last 20 years on thyroxine 50 microgram, and it is a case of chronic kidney disease. So on arrival, she was conscious, oriented, febrile. Pallor and pededema was present with the elevated JVP. No, there was no ictus, no clubbing, no cyanosis, no lymphadenopathy. Vitals on arrival was respiratory rate of 36 per minute, and she was requiring O2 of 10 liters per minute. BP was 120 by 70 millimeters of mercury. Pulse rate was 50 per minute, which was irregular, and GCS on arrival was 15 by 15. And other system examination wise, cardiovascular system examination wise, upper tweet was felt in left side on the fifth intercostal space 2 centimeter lateral to mid clavicular line. There was a palpable P2 with loud P2, and there is a PSM murmur in the tricuspid area. Respiratory system examination wise, fine crepitations in the bilateral infrascapular regions were heard, and parabdominal system examination wise, there was no significant soft and there was no significant organomegaly. Central nervous system examination wise, higher mental functions were normal. Motor system examination at that time, there was no obvious weakness, and angle jerks were absent. There were plantas were flexed on both sides, and there was no sensory cranial nerves or cerebellar deficits. So symptom analysis. So patient presented with non-case of presented with acute onset of breathlessness with chest pain, which was along with which. So we consider, and along with the elevated JVP and bilateral basal crepes. So we consider it to be a syndrome complex of acute decompensated heart failure was considered, and which can be precipitated by an ACS, can be STEMI and STEMI or unstable angina. There was pallor was present, so it can be precipitated anemia. And non-case of CKD, so fluid overload was also considered, and hyper and hypothyroidism was also considered at that time. So coming to investigation wise, SP was 10.1 on arrival with an MCA of 78. Total counts of 9,400 with the neutrophils of 55%. Sorry. Platelets of 2,41,000 and creatinine was 1.61. Sodium on arrival was 115. The potassium was 5.7. Bicarb 15, and we have sent a sodium hyponatremia Burkup also, which showed urine osmolality of 229. But by this time, she has already received diuretics, and serum osmolality at that time is 262, and urine spot sodium was 87. LFT was other than alkaline phosphatase 175, other LFT was within normal limit. Thyroid considered TSH of 9.8 with a normal thyroid hormone T4 of 8.8 and free T4 of 1.11. And ECG showed atrial fibrillation with bradycardia at that time. And TROP-T on arrival was 500, and there was a serial elevation. Not doubling was there, but serial elevation was there. And echo which was happened after the 3 days of admission showed a normal LV systolic function with no RWA, MR mild TR, moderate PH with the grade 2 diastolic dysfunction. So a diagnosis of coronary artery disease, acute coronary syndrome, and STEMI was with MIS score of 4 and grade score of 127. Patient was managed with the therapeutic anticoagulation and DAPT with high dose statin. So while after presentation, we had done an chest X-ray, which showed this. I think I'll put it. So there was a opacity or mass-like lesion in the left upper lobe, and she was having the persistent hyponatremia, which we are trying to correct from ward. Also, it was not correcting. So, and that after giving fluid restrictions and high sodium salt, it was improving. So, and cortisol and thyroid function TSH were also kind of the normal level. So SADH was considered. So an upper lobe lung, left lung upper lobe lesion, which was incidentally detected during routine X-rays. This one. So differentials which we consider at that time, it can be so because of the underlying SIDH, we consider lung malignancy, tuberculosis, lung mets, and any fungal infections, benign tumors like hematomas or fibrosmas are considered. There was no history of fever or anything that suggest of an infection. So we went ahead and did a CT, which showed irregularly consolidatory lesions with spicular margins in the apico-posterior segments of left upper lobe. And just mass size was 5.3 to 3.5 centimeter, and there was subcarinal lymph nodes were also there. So imaging features were suspicious of primary lung neoplasm. So currently she came with acute heart failure, so we managed her medically and we discharged her, and we told her about the possibility of malignancy. So we discharged her and asked her to come back after 3 weeks for a biopsy of the lesion. So we did a CT guided biopsy of the lesion, which showed granulomatous inflammation with necrosis, and experts showed positive for TB with rifampicin sensitive. So diagnostic dilemma of tuberculosis versus malignancy. So there was this journal which is published in medical oncology annals. So there are 37 cases which were misdiagnosed, which were confused between malignancies and tuberculosis. Of them, 26 of them were misdiagnosed as cancer, which were later turned to be tuberculosis. So in their conclusion wise, so what they saying because of the wrong diagnosis is because there is an, even if you do a PET also, PET scan will cause increased uptake in both tuberculosis as well as malignancy, and tumor markers such as CA19, CA125, which could be increased in tubercular patients also, and ADA can be updated in cancer patients, which can also be slightly misdiagnosed as tuberculosis. So this study includes all kinds of, not only lung, it includes all the tuberculosis, including abdomen and neck and thorax, everything. So currently our patient, this gold standard for diagnosis is still histopathological examination and tubercular cultures, but recent advances are coming. So they are suggesting multimodal imaging. That is, other than doing a single CT, we can do a further MRI scan and doing a radiomimics. Radiomimics is a new emerging concept which they are doing analysis of lot of CT scan which is done on patients with CA lungs or different type of CA, and correlating with their histopathology, and they with powerful artificial intelligence and powerful software, they will increase the diagnostic accuracy of the test. So currently it is on process, and for CT for lung malignancy, they have collected a lot of data regarding this thing, and they are trying to implement this radiomimics in future for the diagnosis. So it is a non-invasive method which will improve the diagnostic accuracy in case of imaging alone. So currently our patient, she was started on ATT, weight-based ATT, and she came to OPD after 2 months. She was doing well, appetite improved, and we are continuing the ATT for another 4 months. So take-home points: lung malignancies and versus TB in incidental finding of lung mass and radiomimics.
Thank you. Was this patient's first admission with CMC?
Yes.
We didn't have any prior X-rays to compare. Did we do a sputum examination when she was in the ward?
No, we haven't done a sputum.
Did we do a sputum examination after seeing the biopsy?
We thought we did a sputum examination after seeing a biopsy. Initially, we didn't do it.
Is the sputum positive? Not positive?
No, not positive.
So if you apply critical thinking instead of looking at complicated, costly AIs and PET, the patient actually has tuberculosis. She has all the risk factors. She's got diabetes, CKD, that's what I understand from her presentation. And she did not have any risk factors for malignancy. She was not a smoker. There's a central place malignancy. So you're looking at her as squamous or small, so both are associated with smoke. So if you apply logical thinking as per Stockholm, you know what is TB instead of doing expensive diagnosis. And I agree that you should do a sputum. See, the thing is, there's a cavity there. That means it's open to tuberculosis.
That's what I'm concerned, because 3 weeks delay is not appropriate there.
Yeah. And even if she's unconscious, you would have done a GJ.
Yes.
Domestic.
So please apply logical thinking to your patients rather than look at complicated AI related. The AI is also going to give us hallucinations. So to generate more nonsense for us rather than give us logical thinking. We do not think just to apply logical thinking.
Any more?
Is she ever unconscious?
No, she has.
She's conscious oriented.
Just so.
Minimally confused at
Minimally
arrival.
confused.
And why that bradycardia?
Bradycardia,
Because
hyperkalemia was there, sir, on arrival. So after correcting hyperkalemia, heart rate has been.
What happened to What happened to the atrial fibrillation in the end? How did you manage?
Actually, atrial fibrillation we got resolved by itself, ma'am. By then, after the 3 weeks, there was no atrial fibrillation.
What is the risk factor? What is the difference in any incidence of stroke in proximal AF and regular AF? Because you're assuming that it is also in. What is the difference if a patient has got paroxysmal AF and just regular AF, daily AF, or persistent AF? So what is the difference in stroke risk between both of them?
None.
It is the same. There is no difference. So you cannot say paroxysmal AF, I did not give.
One more comment, please take some effort on the presentation. We do not want to see spelling mistakes on the presentation that has been published. Was she anticoagulated?
No, we had second anticoagulation.
What was her Chadwick scope? She was a non-valvular AF.
No one. She had a TR on echo.
TR caused the atrial fibrillation. Thank you. For the next presentation, we have Ageshwar from Medicine 4.